Good evening, everyone. This is Batul from IJCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. Well, sir needs no introduction at our platform, but it's my pleasure and honor to introduce him. He's none other than Dr. Kumar Praful Chandra, sir, who has done various sessions at our platform and has poured in his wonderful inputs about the topics that has been given to him. So now, without any further delay, I would like to introduce the topic to each one of you. And the topic for today's session is Management of Hyperglycemia and Type 2 Diabetes, ADA EASD Part 3. So now we'll have a brief look on what the topic says. The management of hyperglycemia in type 2 diabetes is a critical aspect of diabetes care. It involves a comprehensive approach tailored to individual needs, combining lifestyle modifications and medication therapy. We'll be learning more from evidence based guidelines such as those from the ADA and EASD, providing valuable recommendations to optimize hyperglycemia management. So, now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you very much, IJCP, MedTalk, and Batul for giving me this opportunity. As described in the background, we are going to talk about treatment of type 2 diabetes, management of hyperglycemia based on ADA and EASD 2023 guideline. So today is the part third of this episode, and what we are going to talk today is about the personalized approach to treatment based on individual characteristic and comorbidities. So the message that I wanted to give is that everyone who is suffering from diabetes or who is living with diabetes is different, and there cannot be one shoe which could fit everybody. So the treatment has to be individualized, and treatment individualization would depend upon the person's characteristics. So let us begin. Why do we need person-centered glycemic management plan in type 2 diabetes? We all know that diabetes is associated with many long-term and short-term complications. So when we treat a patient of diabetes, we wish to prevent the complications that develop because of diabetes. Then comes compromise in quality of life. We all know diabetes as such is a diagnosis which has got a lot of effect on the quality of life, both because of the dysglycemia and because of the complications associated with it. So, whenever we try to treat, ultimately what we want to get in a patient, we want to improve the quality of life of the patient, and then we want to prevent the complications so that the patient lives for a longer duration of life with normal life expectancies. Now, when you start planning treatment, we have to assess the person's characteristics because they are going to decide the line of management. So what are the individual's priorities that comes first? So if you treat a person and the person does not accept the treatment, so writing down a prescription doesn't make a sense. So we need to understand what are the priorities that that person has got in terms of his life, in terms of his work, in terms of his acceptability of the treatment, in terms of acceptability of lifestyle modifications that we are suggesting. Then we need to evaluate lifestyle of the person, his current health behaviors. Apart from that, comorbidities like cardiovascular disease, chronic kidney disease, and heart failure, which is very common in patients of diabetes, have to be evaluated. Some decisions are based on the age of the patient, current HbA1c, and weight. We all know that the way obesity has come up in the management of diabetes, weight becomes an important part in the management of diabetes. Apart from that, issues such as motivation, depression, cognition, social determinants of health are also important. Now, what has happened new from past 1 year is that many outcome trials have come up, and based on that ADA and ESD guidelines have been updated. So this consensus update has occurred. So there were some cardiovascular outcome trial. The data based on these trials have been included in the recommendations so that the benefits that has been seen in the clinical trial can be passed on to people living with diabetes. So cardiovascular outcome trials included Amplitude O trial, Vertis trial, Freedom CVO trial. Heart failure trial included DAPA heart failure, that is DAPA HF, Soloist WHF, Emperor reduced, Emperor preserved. Then renal outcome trials included DAPA CKD and ESCORED trial. Then comes secondary evidence. So whenever you have some clinical trial, one is the direct or first hand experience or original articles that gives us the evidence from the clinical trial. Secondary evidence is when you bring out few similar trial of types of trials together with different drugs or different groups of drug, and then you do the meta analysis, and then you construct some inference out of multiple trials, data from multiple trials put together. So secondary evidences are also there, few publications have appeared, and based on that, this management of type 2 diabetes has been updated. Now, management of type 2 diabetes starts with healthy lifestyle behavior, which includes diabetes self management, education, and support, and social determinants of health. So, before I go ahead, let me tell you one very important thing, that an intervention which is most efficacious, even more than insulin, in management of type 2 diabetes is lifestyle management. Unfortunately, due to scarcity of time or due to scarcity of helping hands in our clinic, patients do not get adequate education about changing lifestyle behaviors. So, the first management comes lifestyle management. Now, let me tell you, there is another aspect in healthy lifestyle behavior, and that is therapeutic inertia, both at the level of physician and at the level of patient. So this should be made a routine that every 3 months, whatever treatment that you are giving and whatever control of blood sugar that patient has, it should be re-evaluated. And if you feel that the treatment is good and control is good, you can continue with the same treatment. Otherwise, treatment modifications should be done. Now, let us move to the next aspect. After this lifestyle modification, second part is when you treat a patient of diabetes, you need to reduce the cardiorenal risk. We all know that type 2 diabetes itself is equivalent to cardiovascular event. It's equivalent to CAD equivalent, coronary artery disease equivalent. So the risk of cardiovascular and renal events are quite increased. We need to consider this. Now, the data that we do have from different trials that I was talking about, presence of atherosclerotic CVD, which is called ASCVD, or presence of indicators of high risk of cardiovascular disease have become a very important determinant in choosing the therapy. And that's why we call personalized the therapy. You have a patient of diabetes, try to see if he has history of atherosclerotic cardiovascular disease, or he has high risk of developing cardiovascular disease, or he has heart failure, or he had past history of heart failure, or if he had CKD. So, depending upon the patient characteristics, drugs have to be chosen. So, let us see what are the definition of ASCVD which were taken in different trials and how we correlate that to our patients. So, if patient has previous history of MI, a stroke, or revascularization, variety of different conditions were also included in different trials, which included transient ischemic attack, unstable angina, amputation, symptomatic or asymptomatic coronary artery disease. So all these are considered together as atherosclerotic cardiovascular disease. And if a patient has evidence of atherosclerotic cardiovascular disease, you should choose those anti-diabetic drug which has got proven benefit in cardiovascular disease. Similarly, indicators for a high risk include age more than 55 years, with two or more than additional risk factor which include obesity, hypertension, smoking, dyslipidemia, or albuminuria. So this group is defined as a group of diabetes patient which has got higher risk of cardiovascular event. And in them, the drug which has to be chosen first is GLP-1 receptor agonist or SGLT2 inhibitor. Let me tell you, out of these two groups of drug, you have to choose those drug which has got a proven CVD benefit. So choose those drug. If HbA1c is above the target, with one drug, use the combination of these two drugs. And even after this, if HbA1c is not within the target range, then TZDs, that is pioglitazone, have been found to be beneficial in cardiovascular disease. They come early. So this is how the line of management has to be decided based on the patient characteristic. Now let us move to the second part. If patient has got heart failure, either current heart failure or prior symptom of heart failure or documented heart failure, either reduced ejection fraction or preserved ejection fraction, in those patients, we do have different trial which came with dapagliflozin and empagliflozin as DAPA-HF trial, DELIVER trial, Emperor reduced, Emperor preserved trial. They have shown that SGLT2 inhibitor is beneficial in heart failure. Hospitalization due to heart failure, sudden cardiac events in heart failure patients are reduced when SGLT2 inhibitors are used. So the message is that if features of heart failure are either present now or there was past history of heart failure or there is any documentation which said that patient had heart failure, you choose SGLT2 inhibitor. The third aspect is CKD. Let me tell you, about 50% of the patients of type 2 diabetes who has got duration of diabetes more than 5 years do have some renal compromise. And the way CKD is defined is EGFR less than 60 ml per minute or albuminuria, albumin creatinine ratio more than 3 milligram per minute or 30 milligram per gram. So if patient has got features of CKD, once again we have to choose those drugs which has been found to be beneficial in preventing the progression of CKD. So what it says that in the background, ACE inhibitor or ARB should be given up to the maximum tolerated dose if it is not contraindicated, and then SGLT2 inhibitors should be given as priority. There is a caveat. Once the GFR decreases, glucose lowering efficacy of SGLT2 inhibitor may decrease, but its beneficial effect in preventing CKD progression, in preventing cardiovascular event in patients of CKD are established. So even if you are not getting adequate glycemic control, but if diabetic patient has CKD, SGLT2 inhibitors should be started unless it is contraindicated or not tolerated. And if it is contraindicated or not tolerated, then GLP-1 receptor agonist should be given. Why to give GLP receptor agonist in patient of CKD? The simple reason is that around 50% of patients suffering from CKD die of CVD. And we know that GLP-1 receptor agonist has got beneficial effect in CVD. Hence, if SGLT2 inhibitors are not tolerated or contraindicated, GLP-1 receptor agonist should be given. So we should supplement SGLT2 inhibitor and GLP-1 receptor agonist in all these cases of diabetes wherever there is any complications or comorbidities. Now, moving ahead a little bit more about how to choose glucose lowering medication in people with CVD. I have already discussed in detail either GLP-1 receptor agonist or SGLT2 inhibitor. If still HbA1c is above target, add one to the other. So this is how you have to do. So the consensus recommendation is that in people with established CVD, a GLP-1 receptor agonist with proven benefits should be used to reduce MACE, and an SGLT2 inhibitor with proven benefits should be reduced to MACE and heart failure and improve kidney outcome. In people without established CVD but multiple risk factors like age more than 55 years, obesity, hypertension, smoking, dyslipidemia, or albuminuria, a GLP-1 receptor agonist with proven benefit could be used to reduce the MACE, or SGLT2 inhibitor with proven benefits can be used to reduce MACE, heart failure and improve kidney outcome. So see the difference. When you are using SGLT2 inhibitor, you are having beneficial effect on all three parameters: major adverse cardiovascular event, that is MACE, heart failure, and kidney outcome. And with dapagliflozin becoming off patent now, and data that we do have from dapagliflozin, now we do have a very good drug in our armamentarium which we can use early, so that all these complications associated with diabetes is reduced. Now let us move to the another aspect, that is meta-analysis of different studies. This analysis is intra within the study, different cohort have been evaluated, and between the trial different cohorts have been evaluated, and some recommendations have come up or some results have come up. So we will go to the right panel and see what are the potential benefit. So when potential benefit in patients of diabetes within 5 years, all cause mortality with usual care, all cause mortality is 70. When you add SGLT2 inhibitor, it comes down to 60. When you add GLP-1 receptor agonist, it comes down to 62. So around 15-20% reduction in all cause mortality. Non-fatal myocardial infarction, you can see with SGLT2 inhibitor, it decreases from 58 to 51. From GLP-1 receptor agonist, it decreases from 58 to 54. What we see that SGLT2 inhibitor is really doing a wonderful job in terms of preventing all these: all-cause mortality, non-fatal myocardial infarction, non-fatal stroke, end-stage kidney disease, and hospitalization because of heart failure. You can see the extent: hospitalization due to heart failure, usual care 30 per 1000, with SGLT2 inhibitor 21, with GLP-1 receptor agonist 28. So almost 30% reduction in hospitalization due to heart failure occurs because of SGLT2 inhibitor, and that's why we say that yes, SGLT2 inhibitors should be used early, and we have to individualize the treatment, and wherever it is needed, we should use. Now, many times it is said that if I'm giving metformin, should I be using these drug? Does background treatment of metformin affect the beneficial effects that we are going to get? So this is once again meta-analysis from different trial, and here you can see that the first one is with SGLT2 inhibitor. There was a 10% reduction in all causes events when SGLT2 inhibitor was used in background of metformin. Then the second and third pictures are showing about use of GLP-1 receptor agonist with metformin and without metformin, effect on 3-point MACE, and all cause mortality. And what we see here is that in almost all cases, with or without background of metformin, these two drugs have shown beneficial effect on all risk factors which were evaluated. Thus, the consensus recommendation says that in people with heart failure, CKD or established CVD, or multiple risk factors for CVD, decision to use GLP-1 receptor agonist or an SGLT2 inhibitor with proven benefit should be independent of background use of metformin. So you are using metformin or not, doesn't matter. If patient has got these risk factors, SGLT2 inhibitor or GLP-1 receptor agonist with proven benefits should be used. The second part is in people with heart failure, CKD, established CVD, multiple risk factors for CVD, the decision to use GLP-1 receptor or SGLT2 inhibitor with proven benefits should be independent of the baseline. So patient may have good controlled blood sugar level. HbA1c may be less than 7 or it may be more than 9. Whatever be, if patient has got risk factor, these two drugs should be added in the treatment. You may have to reduce the dose of other drugs which are being used for diabetes, treatment of diabetes, but these two drugs come up in the recommendation. Now, let us move to the another aspect, choosing glucose lowering medication in people with heart failure. Once again, SGLT2 inhibitor with proven heart failure benefit in this population is important. So in people with heart failure, SGLT2 inhibitor should be used because they improve heart failure and kidney outcome in patients with heart failure. These are once again data from DAPA HF trial evaluating the effect of SGLT2 inhibitor in people with heart failure. You can see cumulative incidence, death from cardiovascular causes, hospitalization from heart failure, death from any causes. in each of these parameters, there is a significant reduction in the outcome which was evaluated. Now, these are the two trials: impaired reduced, that is, use of empagliflozin in patients of heart failure with reduced ejection fraction, and impaired preserved. In both these trials, similar results did come out. That use of SGLT2 inhibitor in people living with diabetes and heart failure did help in reducing all primary outcomes which were evaluated. So what we see, the effect of SGLT2 inhibitor in people with heart failure, a meta-analysis, impaired reduce and DAPA heart failure, result is really mind-blowing. 38% reduction in all the outcome. So kidney composite was defined as time to first occurrence of any component of 50% or higher sustained decline in EGFR, end stage renal disease or renal health. And what did we see? That in these two trials, the kidney outcome, I mean deterioration in the kidney function as described here, was reduced by 38%. So that's why we say that if a patient of diabetes has got heart failure, it not only reduces the hospitalization due to heart failure but also improves kidney outcome. And that's why even in absence of diabetes, SGLT2 inhibitor has become a choice for treatment in heart failure. So this SGLT2 inhibitors are not restricted to treatment of diabetes. Even in absence of diabetes, patients of heart failure are being given an SGLT2 inhibitor because of the drastic benefit that a patient gets, both in terms of cardiac outcome and kidney outcome, which is described here. Now let us move to the another aspect. If patient already has CKD, which is defined by EGFR less than 30 or presence of albuminuria was less than 30 milligram per gram of creatinine. So in this case also, SGLT2 inhibitors have been found to be benefit, and it has been said that use those SGLT2 inhibitor which has got primary evidence of reducing CKD progression. Use SGLT2 inhibitor in people with EGFR more than 20. So you can use it up to 20. You may have less glycemic benefit, but in terms of preventing progression of kidney disease is also important. Preventing hospitalization due to heart failure is also important. And SGLT2 inhibitor with proven benefit, particularly dapagliflozin, has been found to be beneficial. And once it is initiated, continue it until initiation of dialysis or transplantation. When SGLT2 inhibitors are not tolerated or contraindicated, GLP-1 receptor agonists should be used. I have already said that GLP-1 receptor agonists should be used because of its CVD benefit. So that is what we need to give to our patients. Now, another meta-analysis, we will try to understand, we will try to compare different trials with different drugs about use of SGLT2 inhibitor in chronic kidney disease. So Credence trial was used with canagliflozin, DAPA-CKD, that was dapagliflozin, IMPA-Kidney was impagliflozin. See the patient characteristic. Credence trial had patients of type 2 diabetes. None were non-diabetic, none had non-albuminuric. So this is the background. Kidney criteria, EGFR was more than 30 but less than 90, and USCR was more than 300. Here also results were positive. In DAPA CKD, type 2 diabetes and non-diabetic patients were also included. All of them were having albuminuria. More than 4,000 patients were included. EGFR from 25 to 75 was included. And here also primary outcome, kidney outcomes were evaluated in terms of end-stage kidney disease, more than 50% sustained decline in EGFR, renal or CV death. This result also did show positive result. And chronic kidney disease in empagliflozin, diabetes, type 2 diabetes, non-diabetic, non-albuminuric, 60,000 patients, EGFR more than 20. This also had positive result, which says that SGLT2 inhibitor as a group has got a beneficial effect in terms of reducing renal outcome. So the consensus recommendation and conclusions include in patients with CKD, SGLT2 inhibitors and GLP-1 receptor agonists reduces MACE independent of EGFR. In people with CKD, SGLT2 inhibitor also reduces heart failure and kidney outcome. In people with CKD and EGFR more than 20, an SGLT2 inhibitor with proven benefits should be initiated to reduce the risk of MACE, heart failure, and kidney outcome. So the message is that at this much low EGFR, glycemic benefits may be minimal, but yes, benefits on MACE, heart failure, and kidney outcome are substantial, and SGLT2 inhibitors should be used even in such cases. If such treatment is not tolerated or contraindicated, GLP-1 receptor agonist with proven CV outcome benefits should be considered. Now, additional consideration, age is one of the important factors. Type 2 diabetes and older age are associated with frailty, worse outcome, and less benefit. So these trials were evaluated in elderly patients also. Most of the clinical trial do have patients which are young. Representation of patients of more than 65 or younger than 40 is very less. Therefore, an informed decision should be taken regarding using these drugs in older and younger individuals. These are some meta-analysis about these two large meta-analysis of use of GLP-1 receptor agonist and SGLT2 inhibitors and its effect on CV outcome and kidney outcome. These two results, what we do see here, meta-analysis says that age less than 65 or more than 65. The benefits are consistent in terms of three component MACE, cardiovascular death, stroke, myocardial infarction, heart failure hospitalization. And that is true in both category of the drug, GLP-1 receptor agonist and SGLT2 inhibitor. So what we see, selection of medication to improve CV and kidney outcomes should not differ for older age because older age are also benefited and rather they are at higher risk of developing these events, so they should be given the benefit. Medication choice for people who are frail or who have multiple comorbidities may require modification for safety tolerability. Consider de-prescribing or avoid unnecessary medication or harmful side effects such as hypoglycemia or hypotension. So if you are using some drug which has got risk of hypoglycemia in elderly patient, we should reduce that. If there is a drug which has got risk of hypotension, we should reduce that because these event hypoglycemia and hypotension may have more adverse effect on these patients. Now, age, rate of pre-diabetes and type 2 diabetes are increasing in adolescent and young adults. So younger age population, most of them, obesity is a big concern, and in them, we need to treat them early. Younger people with type 2 diabetes are at very high risk of complications and they should be treated correspondingly. Younger people may have more rapid deterioration of glycemic control, which may attenuate response to diabetes medication, and that's why we need to be aggressive. Then comes another aspect, and which is often discussed, that should we start with combination therapy or should we start sequential therapy one by one? So there was a very popular trial, verified trial, which was done with metformin and vildagliptin, and there were three arms. In one arm, metformin alone was given. In another arm, it was started with metformin, but when treatment was not, or when glycemia was not controlled with metformin, vildagliptin was added. And in another arm, vildagliptin and metformin was started to begin with. And the time when this treatment fails was evaluated, and what it was seen that in the early combination therapy had the least risk of failure of treatment. I mean, those patients who had early combination had higher chance of sustained blood glucose control over 5 years of evaluation in this trial, whereas those patients in whom metformin was added, only metformin was kept, or vildagliptin was added sequentially after metformin, they did fail to achieve HbA1c control over longer duration of time, and treatment failure was early in them. Now we move to the next aspect, obesity and weight related comorbidities. We have already discussed about it in my previous section. Care of people with diabetes and overweight related comorbidities such as non-alcoholic fatty liver disease, heart failure, and obstructive sleep apnea should be included in strategies to achieve weight loss. So when a patient comes to you, he is overweight, don't forget to evaluate about NAFLD, heart failure, and obstructive sleep apnea. Now, if you treat weight, if you bring weight loss, if you treat these things, they are certainly going to translate into improvement of quality of life and prevention of complication. The another aspect, race, ethnicity, and sex. This is very important. Many times we listen that patient may not be benefited because he is of Caucasian origin or he is of Asian origin. Let me tell you, these trials have included people from different races, sex, and ethnicity, and irrespective of person's race, ethnicity, and sex, available data suggests that there is no significant difference between the groups in treatment response. Beneficial treatment should be utilized irrespective of the background. So with this, I will like to end the presentation now. Thank you very much. Back to Vatul for taking up further. Batul.
Yes, sir, I'm here. Just give me a minute, sir. Thank you so much, sir. Thank you for your wonderful inputs upon the topic that you have shared today with us. We have received few questions, so I would like to put it across to you. The first question is how to choose specific diabetes interventions and their roles in treating type 2 diabetes.
So this is what we have discussed today. That was the topic. It has to be individualized depending upon the background of the patient. Patient's choice. Patient is obese or overweight. Patient has got which comorbidities. Patient has got risk factors of atherosclerotic cardiovascular disease. What I told about is the first thing is that you have to evaluate the patient, do a good lifestyle modification, behavioral therapy, and support, and then choose the drug which has got proven benefit in terms of comorbidities that the patient has. Most of the time, I would say more than 50% of the time, if a person living with diabetes comes to you, he has got some or other comorbidities: obesity, hypertension, heart failure, NAFLD, CKD. So one shoe does not fit all. You don't have a fixed formula. You have to find out what is the comorbidities, which drug has been found to be beneficial in people living with diabetes with that comorbidities. We do have different outcome trials, and based on that, you have to choose the drug. Thank you very much.
Thank you so much, sir, for answering this question. We will take up the next question, and the next question is what principles one should keep in mind in selecting anti hyperglycemic interventions?
The principle is a couple of things. You have to see that patients should not develop hypoglycemia. Patients should not develop complications associated with use of that drug or side effect of that drug. And then you have to find out what benefit you want to give. If you are targeting weight loss, use those drugs which has best effect on weight. If you are targeting to prevent heart failure, use SGLT2 inhibitor. Avoid hypoglycemia, individualize the target HbA1c, and choose the treatment which has got best long term safety and efficacy in that particular patient. Thank you.
Thank you so much, sir, for answering this question. We will take up the last question for today's session, and the question is, what kind of special considerations are required for patients to what kind of special considerations are required for patients with
Okay,
type 2 diabetes?
okay. So considerations. First of all, see what is the duration of diabetes, what is the extent of glycemia, or what is the complications associated with diabetes the patient has got. Those has to be taken into consideration before choosing the therapy. Thank you. I mean, all these questions were very much generic questions, so there was no specific question which I could describe in detail. I mean, all these questions have already been answered in the talk that I did have today. So if somebody listens these talk, all these answers would be taken up. Thank you.
Thank you so much, sir. Thank you for your valuable time and for sharing the wonderful inputs and clearing the doubts that were here put across. And the way you have shared your views and your information upon the topic with your talk. Thank you so much for delivering that. We hope that all the viewers who are here with us, they must have been here and they must have received the knowledge that they were here for. So thank you to all of them for their ardent participation. With all your
Batul,
last comments, sir.
few people wanted to have link of part 1 and part 2 that I could see in chat. So it will
Yes,
be
yes,
great.
sir.
It will be great if you can, if you could share
Sure,
part 1
sure.
and
We
part 2
will
with
put it
them.
across to
Thank
them,
you
sir.
very much. Thank you very much, IJCP, for giving me this opportunity. We will meet with the fourth and last part of EASD ADA recommendation 2023 next month. Thank you.
Thank you
Bye
so
bye.
much, sir. With this, we are signing off for today.
Bye.